palliative care. And here you see the rapid rise of physicians who are certified in palliative medicine, and we expect this to continue to rise with the incorporation into the American Board of Palliative Medicine. And lastly, we have training programs, fellowship programs. There are now 49 fellowship programs with 9 that are developing, so we hope to have somewhere around 60 programs in all. They've been supported by the Veterans Administration, by the National Cancer Institute, and they currently are turning out anywhere from 60 to 80 new fellows a year who potentially will take on leading positions in palliative care in the country. This is again a very busy slide, but I ask you only to look at the top. Our VA system, which takes care of 1 in 7 Americans, has put great emphasis into palliative care and been enormously supportive of this effort, has developed inpatient units, training programs, and a very robust research program. So there's a government support within that area. Yet we still continue to suffer from a lack of research in this area. We've had 2 state-of-the-science meetings supported by our National Institutes of Health. But the sad issue is that less than 1% of NIH funding goes to pain or to symptom management. And there have been a series of initiatives, but it's still a very small percentage of research dollars. So as we look to the future, and as we wish to build this field in Italy and Europe and the world, we continue to need support for better research to provide the evidence base that is so critically needed. Let me end with another part of the good news, is that every bit of effort has begun now to look at the economic impact of palliative care. And this is from a study in one of our cancer centers in the United States at the Richmond, Virginia, that put a palliative care unit into a cancer program. This was work done by Dr. Smith and his colleagues at the Virginia Mason Cancer Center. If you put an expert into the palliative care unit, if you measure pain, if you provide chaplain care, if you talk about hospice, if you provide family with support, you have very positive outcomes. And these positive outcomes are that pain is measured, hospice discussions occur, the patients are seen by an expert. But more importantly, the savings to the institutions are millions of dollars. And these millions of dollars are with appropriate, competent, compassionate care. So the evidence would suggest, at least in some settings, that palliative care is cost-effective and, if anything, maybe cost savings. And so there's been increased attention to how important this is in providing compassionate, competent care that is cost-effective. Lastly, the American Cancer Society, that has been very reticent to talk about dying, has published a textbook for the public, which is called When the Focus is on Care. It took a lot to have that be the title of this book, because their only focus has always been cure. So we think that just the title of this book has been transforming to the American Cancer Society, who is willing to argue that care and cure are both critically important, and to emphasize the care book. And this care book talks very openly about the fact that with cancer you may die of your disease, but that there are so many different choices and appropriate care systems that patients and families need to be aware of them. So let me end by suggesting that we still have a long way to go in the United States. I think we've been able to see in the last 30 years and clearly in the last 10 to 15 years enormous advances. But again, there's much work to do, because we continually have to debate this issue of curing and caring. And therefore, we don't want it to be a cure versus care. We want it to be a cure and care. This needs to be the mantra that we are all arguing for. We desperately need more research. And this is just one experience, one example, but suggests that with public and private partnerships, with the development of young new leaders, with the importance and recognition of this field, we can really make a difference in the lives of patients and families, and there's much work to be done. So thank you.
Grazie. Grazie a Kathleen Foley, perché ci ha dato uno spaccato di una situazione di un paese che per l'Italia e per l'Europa è sempre stato un paese verso il quale guardare con attenzione, e saremo sicuramente tutti molto attenti nel vedere eventualmente cosa potrà cambiare in questo paese con questo nuovo cambiamento politico che c'è stato ultimamente. È molto interessante, lo ribadisco, vedere come in un paese dove la medicina privata è stato il dogma dell'assistenza alle persone, comunque il settore delle cure palliative sia rimasto e si sia sviluppato come un settore trasversale. Un'unica annotazione, perché se no non ci capiremmo: attenzione che in Stati Uniti hospice non è come lo intendiamo noi la struttura, ma va inteso come hospice program, cioè quello che noi intendiamo come network di cure palliative, perché altrimenti questa considerazione potrebbe avere delle conseguenze molto forti nel nostro paese, dove, lo ricordo per gli amici stranieri, l'impostazione della programmazione nazionale vorrebbe che il 75% dei malati, utenza potenziale, brutto termine, ma dei malati potenziali, possa essere assistito a casa, e il 25% in strutture che in Italia vengono chiamati centri residenziali di cure palliative e hospice. Comunque, come dicevo stamattina, la cosa interessante è come, al di là dei modelli internazionali, quello che è trasversale è la risposta ai bisogni delle persone attraverso la continuità assistenziale, la formazione e l'empatia. E l'empatia è data da tutte le persone come Kathy, che vanno in giro per il mondo e che praticamente ci portano conoscenza, cultura e stimolo. Grazie, e adesso facciamo un intervallo.